have a couple of questions. If a physician appeals a claim and it goes to an appeals judge, what percentage of those appeals of those claims are overturned by the appeals judge? Do you have an estimate on that?
I do. I actually have the numbers. If you think about it in three buckets, so you've got think about the total amount that has been overturned, total amount that's been denied by the REC. Of that total amount, roughly 4.5% ultimately get overturned on appeal. Of that total amount, the number that are appealed is roughly 13 to 15%. So you get 100 claims, 13 to 15 of those get appealed, and of those, roughly 30% get overturned. So it's an ultimate overturn rate of about 4.5%. And that compares, it actually compares favorably or not favorably, however we want to think about it, with the appeals rates that we see with our normal FI and carrier operations who also do this sort of work.
That's what you want to ask. You want to know what's the appeals rate for the FI and the carriers.
Okay. Well, we're talking about some issue. What is the appeal rate for the FI and the appeals carriers?
Those rates are about the same.
They're all the same?
Right. The initial, so the 13% is probably a little lower, right? So fewer of the denials are appealed, but of those denials that are appealed, more are overturned for the FIs and the carriers. It's closer to a 50% overturn rate.
Do you have any classifications of claims that are automatically denied on the first time they're sent?
I do, but for the FIs and the carriers, sort of the way we do that normally through the systems process, that's knowable. I don't know that here. I can get back to you for that on the record.
My physicians frequently tell me that they'll submit a claim and it's just automatically denied. And I just wonder why we do that sometimes in federal government.
Well, there are certain circumstances where we have what we characterize as correct coding edits, so that it looks at the claim and it makes a judgment as to whether the system makes a judgment as to whether or not that procedure matches up with a particular diagnosis code. You know, sort of the procedure for fixing a broken arm wouldn't match up necessarily with a diagnosis of pneumonia. So those might get denied. Mm-hmm. Others are what we call medically unbelievable edits. So certain amounts of procedures that are done on a particular day, the system would look at that and say, well, that's medically sort of unrealistic that would happen, and those would get denied on their face. And so I'm not going to say that there are certain circumstances that they would be believable, and in those cases they get appealed and get overturned.
Do you know of any particular illnesses that are denied on the first claim?
Illnesses? No. Other than things that would not have been normally covered for Medicare, but I can't think of any that would be illnesses that would be denied on the first blush.
What do you think is the root cause for the improper payments by the CMS contractors?
I think that there are roughly four categories of improper payments that we see. We see improper payments that are the result of medical necessity. Those are the hardest ones. Those are the ones where we're going in there and we're saying the physician made a judgment to admit somebody into a hospital or to a facility and do a particular thing to a particular person that perhaps could have been done in a different setting or should not have been done. Roughly a third are what we characterize as coding. You know, they just coded it incorrectly. The person needed the service, they got the service, somebody just put down the wrong code for that service. And roughly a third are what we would characterize as no documentation or insufficient documentation. So something was provided, but the information that we got back from the facility, there's not enough information in the record that we got back from the facility to support whether or not it should have been provided. So it's those third. And I think sort of why do they occur? I mean, some of it is Medicare, and medicine is very complicated, and sometimes the rules are tough to follow, and so that's an obligation for CMS to do a better job on provider education and outreach. Sometimes it is people trying to game the system. As much as we don't like to admit it, there are people who try to game the system, and sometimes they're just straight-out mistakes.
But in light of that, do you think the proliferation of the contractors helps or hinders the medical service providers' ability to deliver care to their patients?
Ultimately, it's CMS's position that it's going to help. I mean, I'm not going to I understand the issues around RACs and sort of what the provider community in particular believes. I think it's or sort of perceives as some of the issues. My judgment has always been as CFO that, a physician or a supplier or a home health agency should have confidence in the process they're in. They may not like the outcome, right? They may not like it that a claim was denied or perhaps something was covered or shouldn't have been covered but was. they may not like the outcome, but they should walk away from the process saying CMS was fair, they were predictable, we knew what was going to happen in the process. And that's what we're striving to do with all our integrity efforts, and with the RACs in particular. We learned a lot in the demo. I mean, I'm not going to say that I achieved that vision in the demo all the time, but we strove to, and I think as we roll this out nationally, that's what we're seeking to achieve.